Did you know that postpartum depression is the most common complication of childbirth? Did you know that there are more new cases of mothers suffering from maternal depression each year than women diagnosed with new cases of breast cancer? Did you know that the American Academy of Pediatrics has noted that maternal depression is the most underdiagnosed obstetric complication in America? And despite all of this, maternal depression and other maternal mental health disorders largely go undiagnosed and untreated. So I also want to talk just a little bit about the name and what is in a name. So most of you have heard about the term postpartum depression. We also often abbreviate postpartum depression to PPD. So we like to point out, though, that when it's used as the umbrella term, it's used incorrectly. And that's because disorders can happen not just in the postpartum period, but also during pregnancy, and that there are numerous other disorders that we call maternal mental health disorders, not just depression. We do also want to point out, though, that postpartum depression is the clinical diagnosis that has been researched the most, and therefore we often talk about postpartum depression more often than other disorders like anxiety. So perinatal mood and anxiety disorders, or PMADs, is another term that is often used to describe these range of disorders, and it's most often used by clinicians. What we found is that it can be confusing to lay people who may not understand what perinatal means or mood means exactly. And we've also been approached by advocacy organizations like the National Alliance for Mental Illness, NAMI, and Mental Health America, who've requested that the terminology or acronym MAD, used in the acronym PMADs for perinatal mood and anxiety disorders, really should never be used to describe mental health. And we agree. Even though it's a clinical term, we agree that there's something that we can do about it. Other groups and states have experimented with other terms, including pregnancy-related depression, and that's a term that's being used in Colorado. Emotional complications is a term that's being used in Massachusetts. And then we just like to point out that we found maternal mental health, that terminology, is becoming more widely adopted and also is something that's understood by many. So throughout today's presentation, we will use this term, maternal mental health or maternal mental health disorders, but really want you to know all of these things are often used to refer to the range of disorders. So I get to turn it over now to Dr. Hibbert, who's going to introduce to you the range of disorders, and then after we go over the range of disorders, risk factors, and also impacts to fathers, we'll talk a little bit about the things that you all can do as employers and business groups on health to help us move the needle. So Dr. Hibbert.
All right, great. Thank you, Joy. Well, first of all, we're going to start off with the baby blues, which is probably a term that many people have heard of. It's not technically considered a disorder, but it is the most common experience that women may have during after childbirth in the postpartum period. So that impacts about 75 to 80% of women. I mean, that's 4 out of 5. So most women can expect that they're going to feel sort of mild depression that might be mixed with some happier feelings. A lot of women describe it as an emotional roller coaster. And again, it doesn't necessarily require professional treatment because if it's truly the baby blues, it should go away within a few days to weeks after delivery, and the symptoms should sort of, subside on their own or with some practical self-help and help from others. If the symptoms end up getting worse, or if they persist longer than 2 weeks, then we're talking about postpartum depression. And postpartum depression actually can begin in pregnancy. And that's a really important part that recently was actually acknowledged and changed in the diagnostic manual for clinicians like myself or psychologists and psychiatrists, they changed the term from postpartum to peripartum, which means pregnancy and postpartum. So finally, we're getting some acknowledgement that these disorders really do happen in pregnancy and postpartum, and that there is sort of this time period that exists beyond just after the baby's born. And so if we look at pregnant women, about 10% will experience depression, and about 15% of postpartum women will experience depression. And the symptoms are what you typically think of, like sadness and crying, although it includes things like insomnia. A lot of times with a regular depression that's not perinatal or pregnancy or postpartum, you might see people sleeping a lot. In this case, a lot of women are not sleeping. They feel like they can't sleep. They will still have appetite and other kinds of sleep changes, difficulty concentrating, making decisions, and a lack of interest in usual activities. And these are kind of the basic symptoms of depression, a major depressive disorder. But if we go on to look at the postpartum and pregnancy type of depression, you also see things like anger and fear, or maybe feelings of guilt, probably feelings of guilt. That's actually quite common. Obsessive thoughts of how badly the mom feels she's doing, especially because she wants to be at her best and she doesn't feel like she can be. And that can lead to feeling worthless, feeling overwhelmed by all the demands that are happening while being sleep deprived. Anxiety is a part of pregnancy and postpartum depression for many women, and they might have racing thoughts. And all of these things can lead to a feeling of disconnect from the baby, maybe having trouble bonding for some women. And of course, at the extreme end, suicidal ideation or thoughts can be part of this depression as well. Now, anxiety is another common experience for women in the pregnancy and postpartum periods. It impacts about 6% of pregnant and 10% of postpartum women. And like I said, can also be an element or a part of depression in pregnancy and postpartum. But anxiety has had kind of a rougher case as far as being diagnosed and getting treatment, because a lot of people just think it's normal, it's okay, it's the way it is, that you're going to, quote, be worried as a mom, and don't fully understand that anxiety is different than just everyday worry. So anxiety is really constant worry. You can't shut it off. You feel like something bad is going to happen, and it's an intense feeling of worry that can make you feel even panicked at times. Your thoughts might be racing. You can't shut them off. When you're trying to sleep, you can't turn off your brain in order to fall asleep at night. It can change your appetite, lead to digestive issues, especially with all of the worry and the stress can lead to those problems. Can't sit still, and it can even lead to physical symptoms like dizziness or hot flashes or heart palpitations or nausea. And often women with anxiety are misdiagnosed as having something physical that's the cause of the disorder versus having this emotional mental health issue called anxiety. Now, when we talk about anxiety, there's also some other types of anxiety, and we separate these into different disorders. And you might have noticed the title page for all of these disorders we're talking about said the spectrum. And by spectrum, I mean there's a broad range of what can happen. And as Joy pointed out earlier, that term postpartum depression is what most people hear. And they might think that that means that you're depressed, or that means that you're anxious, or that means that you are experiencing psychotic symptoms. But what we're talking about here is that there really is this spectrum of disorders, and you might have any one of these on the spectrum. Not necessarily that any of these lead to another, but just that there are different types of disorders that women experience we need to understand. And postpartum panic disorder is one of those, and it's a type of anxiety disorder where women experience extreme anxiety that causes panic attacks. And the panic attacks are usually heart palpitations, shortness of breath, chest pain, and agitation. There's excessive worry or fear, usually about dying, going crazy, or losing control. This is often very misdiagnosed because, again, of the physical symptoms, but it does affect up to 10% of women. And then we have pregnancy and postpartum obsessive compulsive disorder, which impacts 3 to 5% of women, but is considered the most misunderstood disorder. And it's a very difficult one for mothers experiencing it to cope with and to come to terms with, because the symptoms can seem so scary to them. What this is it's obsessions, which are, in general, obsessions are intrusive thoughts that are kind of unwanted. They come into your mind without you wanting them to come. In the case of pregnancy and postpartum OCD, we see persistent thoughts and images, almost like a picture. So if you imagine just seeing a picture, a movie in your head of usually something harmful happening to the baby, the pregnancy, or to her parenting, or something related to the baby. And you can understand why that might be incredibly scary to suddenly see these images in your mind or have these thoughts that come in. The compulsions then are behaviors that try to reduce the distress that the woman would feel. And often in postpartum and pregnancy OCD, they include things like avoiding things that they feel might be dangerous to the baby. Even sometimes avoiding the baby, putting the baby in his or her crib and sort of leaving them alone because the mom doesn't want to have any of those things in her head come into real life. There's this sense of horror about these thoughts and images. And that's a really important point, because a lot of times this is misunderstood and misdiagnosed as psychosis, in which there is no sense of horror about the thoughts and images coming into one's mind. So in this case with OCD, you might see women who are much more likely to protect the baby by staying away from the baby, getting other people to take care of the baby. I've had clients who lock the doors at night and won't sleep in the same room with the baby because they're so afraid that what they're seeing in their mind or thinking is going to happen. But the fact that they actually know that that's not right, that there's that sense of horror, shows that they are not psychotic, and that, you know, it's not likely to happen. In fact, we have no report on record of an OCD mom ever harming her child. She's much more likely to harm herself or take her own life than she would ever be to hurt the baby. And there's that hypervigilance about protecting the baby. And then contrast that with psychosis, which can sound kind of similar, but this is a much more rare disorder, which only affects 1 or 2 out of every 1,000. That's only 0.1 to 0.2% of women. And this is where a woman experiences delusions or hallucinations. And let me just explain that delusions and hallucinations differ from obsessive thoughts, because, again, a delusion is a false belief you believe. You believe that it's true, that it's good, that it's okay. The hallucination comes in and you are believing it, you're going with it. So you're sort of not in your right mind when you are in a state of psychosis, versus in OCD when you're having obsessive thoughts that are intrusive and showing you an image and you're thinking, what is happening here? This is horrible. I hate, you know, I don't want to see this. A woman with psychosis, on the flip side, might have a voice telling her to do something, or see something telling, you know, showing her what she needs to do, and she thinks, yes, this is good, yes, this is going to help me, yes, this is going to help my children. Or often delusions include believing that they're saving their children by doing harmful things to them. This is a very extreme disorder. It can include extreme insomnia, extreme mood shifts, confusion, poor judgment, very irrational thinking, and changes in personality even. You know, sometimes it's not even scary what these women are thinking, but it's just so different from normal functioning. And all of these things mean that this is a medical emergency. So when there is psychosis, when a woman is not in her right mind, when she seems like she's completely different than she used to be, when she's thinking that the thoughts that she's having sound like a good idea, or that she doesn't feel horrified by the thoughts that she's having about maybe harming her child or harming herself, we need to make sure that she gets treatment immediately. And hospitalization is the treatment of choice. Definitely take to the hospital, get her admitted and evaluated and put on medication. Most women, almost all of them who've had postpartum psychosis before, will have it again. And we also know that women who experience bipolar disorder are at a very high risk of developing psychosis. So the sooner we can prepare for these things, the better. And then finally, we have postpartum post-traumatic stress disorder, which is actually another form of an anxiety disorder. We've all heard of PTSD for war veterans, and this can happen for women. Up to 6% might experience PTSD following usually a traumatic childbirth experience or some other traumatic experience around the child, the pregnancy or the childbirth experience. And that includes flashbacks, re-experiencing that trauma, avoiding anything associated with it, not wanting to talk about it, not wanting to think about it, and then this hypervigilance. You feel like you're kind of always on guard and can't calm down. It can include anxiety and panic attacks and a sense of detachment or not feeling quite always real, where sometimes you feel like you're in a dream. That's very common with PTSD. So we need to remember that trauma is very common in pregnancy and childbirth and postpartum, and that can definitely lead to these kinds of emotional symptoms as well. So what causes perinatal mood and anxiety disorders or maternal mental health disorders, as Joy said earlier? In general, we kind of break it down into three categories. We have the physiological, the psychosocial, and pre-existing vulnerability. And just to give a quick example of each. So physiologically, we've just been through childbirth. We've just been through pregnancy for 9 months, which ended in this labor and delivery experience. And that is exhausting, and it takes time to heal. And yet, women don't often get that time that they need to heal. And including, if you add into that sleep deprivation, which starts right off the bat, you never have known how tired you can be until you have a child, you have a new baby, and you just are never sleeping. And that is a huge factor as well. And then you have psychosocial factors on top of that, which are sort of what are the expectations of you? What are the beliefs, the sort of myths of motherhood that you're supposed to bounce back quickly and that you're supposed to feel happy and everything's supposed to be fine, or the myth of the perfect baby or the perfect mother or the perfect mothering instinct. And also things like grief and loss, which are ironically part of this postpartum experience, especially for women who have these disorders, because there's the joy of having the baby and then the sorrow of what you're going through emotionally. And then you also add on to that a vulnerability, and that could be anything such as being sensitive to shifts in hormones. So women who have previously been sensitive to taking hormone-related birth control, women who've had significant PMS symptoms, all of those things mean that you are at a higher risk of being sensitive to the dramatic shifts in hormones that happen during pregnancy and postpartum. So combine all those, and every woman might have a different combination, but that's kind of how we figure out why they're caused. And then we look at the risk factors. We know that maternal mental health disorders can affect all mothers regardless of race, culture, age, or socioeconomic status. So this isn't just one population that experiences these experiences, but there are certain risk factors that can put a woman at a higher risk. For instance, her personal history, any history of a maternal mental health disorder, especially, like I said, psychosis previously, bipolar disorder, really puts her at high risk, or any other mood disorder. And again, see, that's personal or family. And a lot of times we don't talk about this with our families. In fact, most of us never knew that our mother or our grandmother had postpartum depression or anxiety or even psychosis until we have our own childbirth experience and maybe are going through the similar things. So if we can talk about these things as families, that can help us know if we're at risk. Sensitivity to those contraceptives, as I mentioned, the birth control or severe PMS. Infertility is another risk factor. And really, if you think about it, women who go through and couples who go through that process of infertility, it's such a stressful process. And there's that, buildup of hormones and emotions, and then the letdown, and this process goes on. And so that can be a big risk factor. Also, history of abuse, which can be a triggering factor, especially during childbirth, kind of bring back that abuse, especially sexual abuse. Also, when we look at support, an unstable relationship with a woman's partner or parents is actually one of the most common risk factors. So if you look at the top of each of these, their personal family history, that's probably one of the biggest risk factors. And then under support, the biggest risk factor would be an unstable relationship. And yet, how many couples think, you know what, we're having a rocky relationship, let's have a baby to make it all better? And unfortunately, we know that that's just not the case. In fact, it's likely to make the stress so much worse for the couple. Poor support system and poor relationship with one's own mother can be a risk factor as well. And then, trauma. I mentioned trauma a few minutes ago. So having that traumatic childbirth experience or any kind of recent trauma or stressful event, if you've had a death in the family, I find that most women that I work with in this time period of their life are moving. So even just having a stressful move can be traumatic for some women, you know, just depending on what it is, or having that life, those big life events that are stressful can be a risk factor. And then we have certain personality traits or expectations that are part of this as well. For instance, unrealistic expectations of parenthood. I mean, this happens all the time. Again, related to those myths of motherhood, we're not told how hard it is. And we're often not prepared for just what the reality is going to be. So we have these ideas of being this perfect mother and what that looks like and how I'll feel and how happy I'll be. Or, you know, our partner might have ideas about that, and then the baby comes and we feel like we're a mess, and we feel like we can't do anything right, and we feel like we're just not doing this mother thing right, and those expectations can really set us up for failure if we don't check them ahead of time, especially that expectation of oneself. And we find that perfectionistic or high achieving types of personalities tend to experience perinatal mood disorders because of, you know, just those expectations on themselves and feeling like they can't let help in. They need to do it all themselves. And finally, practical concerns. So yes, things like having financial stressors and low socioeconomic status and cultural concerns as well can be part of risk factors. All right, so if these are the spectrum of disorders, and we just did a very brief and quick overview, let's look at how these can impact that return to work question, which is often, you know, so much in the forefront of the woman's mind, the family's mind, her partner's mind. And there's just so many questions that revolve around this issue of return to work. First and foremost, usually for most women, is what's best for my family? Should I go back to work or should I stay home? And trying to figure out sort of what the family needs are as far as her working and how much she'll work and what that will look like. Really focused on what's best for baby. Most mothers really, even when they're depressed and struggling with anxiety and OCD or panic disorder, whatever it may be, still their main focus is wanting to be the best mother they can be and wanting to have the best for their child. So there really is that thought of what is best for baby, and there can be a lot of guilt around the decision to return to work. She may know she wants to return to work or she needs to return to work, but that guilt of leaving the baby at the childcare or wherever it might be is a big question. And of course, it comes down to what's best financially as well. For many couples, there isn't an option of return to work. So it has to happen because of financial reasons. And then there's that question in there that's italicized, what do I actually want? If mothers are lucky, they get to ask that question, what do I actually want to do? And not every mother gets to ask that question. But that question even is mediated by all these others of what's best for everybody else. And does that fit with what I want? Perhaps a woman wants to go back to work, she misses her work, but she just feels so guilty about leaving the baby, or they can't afford childcare, or, you know, there's so many issues that can come up with this. Then there's these questions of what about breastfeeding? If she's breastfeeding, does she feel like she needs to quit? Can she breastfeed? Can she pump at work? Is that a safe environment at work for her and conducive to that type of, you know, pumping and continuing the breastfeeding? Or is the work environment itself saying, no, you probably shouldn't do that? And childcare, of course, you know, finding a place that she feels comfortable, that they feel comfortable leaving the baby, and, you know, just wondering about her own self. How am I going to be able to do all this when I'm so tired, when I'm struggling with depression or anxiety? I mean, if you have that on top of just the regular decision, that makes it even harder. And so all of those questions can lead to many emotions, and there can be a variety of emotions, but there are some that are pretty common. The first and foremost being guilt. So many women that are returning to work, even if they want to work, even if they're excited to get back to work, I find that most women at some level have some form of guilt about leaving the baby, especially at first, about not being able to be there, or feeling like they're not there enough, or wondering if the baby's getting the proper care. That's a biggie. And that can lead to feeling very conflicted about this return to work process. and conflicted about, is this the right decision? And I see this all the time with my clients in my psychology practice, just these questions of, did I make the right decision once they've gone back? And finding it very difficult at work because they miss the baby while they're at work, or they feel like they're missing out on the baby's first moments, let's say. So it can be very uncertain of just, did I make the right choice? And kind of questioning oneself. Also feeling like I can't win. No matter what I choose, I can't win. So if I were to work, then great, we have the financial support and I can go do my job, but I feel like I'm losing at home with my baby. Or if I stay home with the baby and don't go to work, I'm missing out on that financial support and also my job that I might love. It can be very frustrating. There's also a lot of fear about returning to work, not only because of this idea of what you're leaving at home and what's it going to do to the child, but also what is the work environment going to be like post-baby. And we all know that depending on where you are in your work environment, some of those environments are really supportive and conducive to helping a mom through that transition and helping her feel like she can still be the mother she needs to be and do her job well, and many are not. So that fear, that misunderstanding, feeling misunderstood by others, maybe returning to a work environment where you feel like nobody else has children, so they don't understand how you're feeling, and maybe there's expectations from your employer that are going to make it harder for the woman, but also those expectations from yourself and from your family, which can lead to just feeling overwhelmed and sort of, how on earth am I going to do this all? And of course, we see that a lot of times, women that are returning to work and maybe haven't figured out completely the right balance or how this process is going to work best, end up being exhausted and can lead to long-term burnout as well. So we've been talking about the mother the whole time, and we need to mention that the fathers and partners have their own experience around this. So if you are a father or partner, you are also obviously going to be impacted. If a mother is going through all of these things and experiencing depression or anxiety or OCD or panic or especially psychosis, your whole world will be flipped upside down too when you're the father. And we know that there's a wide variety of things that a father may feel and experience. But some of the common things are, first of all, he is also sleep deprived and exhausted. He's trying to keep up with his job and his work and still keep up with the demands at home, which now might include a partner who has a perinatal mood or anxiety disorder, a maternal mental health disorder, right? Depression or anxiety, and that can impact the whole family unit. So that can make him feel frustrated with her and feel like she's not really a partner. She's not really able to be there for me. I've heard many men describe it as, it's like I had two babies. I had this beautiful baby that we had, and my wife was like a baby too, because she couldn't take care of herself, and I had to take care of her just like I did the baby. So it's almost like feeling like they're taking on the mother's role as well if a mom is severely depressed or anxious or really having a hard time or in treatment. He can feel like he can't do anything right. I mean, couples feel like this all the time anyway, right? So, of course, during this incredibly stressful time, which I will add is one of the highest, most stressful points of a couple's relationship, is during pregnancy and postpartum, especially postpartum. And so, feeling like you can't do anything right, wanting to fix the problem but not knowing what to do, and that can lead to feelings of anger. A lot of men tune out with work or hobbies to just deal with what they're feeling. Many turn to substances or alcohol to deal with what they're feeling. Men are less likely to actually talk about these things and to seek help, but we also know that men, yes, they can get depressed as well. There's actually something called paternal postnatal depression, PPND, and I believe there's a slide in the appendix at the end that you can learn more about that, but an estimated up to 14% of men in the U.S. have paternal postnatal depression, which is similar to a mom's postpartum depression. And we also know that when one partner is depressed, so if mom's depressed, there's a 50% chance that her partner is going to be depressed as well. So a lot of times it's couples who are depressed, and we definitely don't want couples who are depressed. That's going to impact the baby for sure.
Great, and Dr. Hibbert, it's Joy. We would like to take a quick pause and invite those of you who are with us to actually use the question feature on the GoToWebinar control panel. We'll just take a quick pause and see if there's any questions about these clinical disorders or emotional experiences that both mothers and fathers might feel. We'll also have some time at the end of the session for question and answers, but wanted to see if there's anything burning that folks want to ask. And again, you can type in your question into the question feature in the GoToWebinar control panel. And it doesn't look like we have any questions coming in right now, so we'll go ahead and open the phone lines at the end of today's webinar. But we'll turn it back to you then, Dr. Hibbert, to wrap up. Why are women not getting the help that they need and speaking up?
Great, thank you. Yeah, that's a big question because we know that so many suffer. As Joy said, those statistics at the beginning, so many suffer, which means so many partners are suffering and so many families are suffering. And yet many women don't speak up and don't get the help that they need. And the biggest reason is stigma. And stigma can show up in many different ways. First of all, there's just general mental health stigma, which we've all seen and probably experienced in our own lives. That idea that if you have something not right with you emotionally that feels wrong, then you are, quote, crazy, or you're not good enough, or you're weak, you can't handle things. I mean, that idea of being weak because you're depressed is so prevalent. I still see that all the time in my practice with my clients. And that's part of that general mental health stigma that we've been all working so hard to overcome. And I do see improvements, but it's still there. And then you have, on top of that general mental health stigma, this incredibly intense stigma surrounding maternal mental health disorders. Because, as I kind of alluded to earlier, this is the time when you want to be most on as a parent, as a mother, as a father. You want to be there for this new child. This is your first introduction to parenting. And when you feel like you are depressed, you're removed, you're not bonding with the baby, you're anxious, you're panicking, you're having these obsessive images floating into your mind that show you horrible things happening to the baby and you're horrified by it, that leads to a lot of guilt and shame. And that idea that I must be a bad mom because look at all the other happy moms and they've all got it together, they can all do it, and I can't. So that maternal mental health stigma is especially strong, and women are very hesitant to say there's something wrong because they don't want to be perceived as that bad mom. And also because people don't understand. So we have family and cultural stigma and shame. I mean, a lot of times women reach out to their family members, let's say a parent or a grandparent or somebody in their family, and the family itself is providing that stigma. No, we don't talk about our problems, or no, you're not depressed, you're fine, you can do this, just pull it together. Sort of a misunderstanding, which can just be a family issue, or it can be part of a bigger cultural perspective on mental health issues and mental illness, which we see in certain cultures. Seeking treatment is considered not okay. Going to a psychologist for counseling or going to a psychiatrist for medication or whatever you might need to do, that alone might bring its own level of stigma and shame in certain cultures and families. And then finally, we have this whole population who really do speak up and they try to get care, and then they're shut down because of so many barriers just in the access to care. And that might include not having maternal mental health providers, especially those who are knowledgeable about these disorders, about this spectrum. We've seen so many times women who do speak up and they're misdiagnosed. For instance, a client of mine who had suffered from postpartum OCD and was misdiagnosed with psychosis and put in the hospital on antipsychotic medication for a month, and her baby was removed from her care because they thought she was a danger to her baby, when really what should have happened is she should have been put on an antidepressant or an anti-anxiety medication, and she probably would have and given some therapy, and she would have been able to be just perfectly safe with her baby. So it was very traumatic. So we see that people don't understand, even providers don't fully understand these disorders, and that's why Joy and I and so many like us do the work we do. There's also that just provider bias that can happen as well. So even if they don't misunderstand the disorders themselves, sometimes they just have their own biases. You know, they might have that cultural perspective of, you know, oh, you're fine. I personally suffered from depression, and when I reached out to my doctor, he just said, oh, you're fine. Everybody, you know, feels a little bit like this, and everybody stresses out when they have a baby. Here's a pamphlet on the baby blues. So again, a provider bias, misunderstanding, and then that just access to care, being able to get in and use their insurance and afford care. That's a huge issue as well.
Great. Well, thank you so much, Dr. Hibbert. I'm going to take it from here. And Dr. Hibbert has joined us and taken time out of her very busy schedule at a conference. So she is going to be available via email for additional questions. And we'll also have time to ask questions at the end of the session, including questions on these clinical issues. So thanks again, Dr. Hibbert, for being with us today. And I'm really excited to go into sort of the detail and the meat about today's session. And first, just want to, again, acknowledge just the importance of having a little bit of overview. It may have felt like a lot, and you may be thinking, well, do I really need to know all of that since I'm not a clinician? And certainly you don't need to know all those details, but we wanted to give you an option to learn about that spectrum of disorders, and know that you can come back to this deck at a later time if you have questions or comments, or come back to Dr. Hibbert or myself. So let me tell you now, when we talk about sort of the change agents and laying the groundwork for change and improving diagnosis and treatment, what are the core beliefs? What do we need to do to make a difference in this system? And first I want to share that the movement believes that OBGYNs should serve as the home base for screening, treatment, and referral. And let me just stop and talk through that for just a moment. So you already heard that these disorders can happen as frequently during pregnancy as in the postpartum, or nearly as frequently. We also know that there are some women that have pre-existing depression or anxiety, and now more than ever, those of you that are working with young employees, we know there's higher and higher rates of pre-existing depression and anxiety in particular. So we believe, the cause believes, that OBGYNs really should serve as the champion for maternal mental health in diagnosing and treating and referring. There have been recently a list of core competencies that we have identified that we want OBGYNs to meet. So what are the basic things they need to know? They don't have to be experts in everything maternal mental health, but there are basic core competencies outlined, and I'll tell you where you can learn more about those competencies if you're interested. And we also believe that this screening and identification of risk factors should happen pre-conception at a well-woman exam, and that, again, OBGYNs are in the best position to do that and ask for mental health history, or even screen to diagnose pre-existing and undiagnosed depression and anxiety, or even bipolar disorder. Again, we want to see these conversations happen in preconception, but also during pregnancy and in the postpartum period. And you might be thinking, well, don't OBGYNs only see a mom once during the postpartum period, and is that enough? And what the cause believes is that OBGYNs, if a woman is used to being screened for maternal mental health disorders and talked to about risk factors, that she will naturally go back to her OBGYN for assistance, who can bill for those office visits when and if a mother comes back and is in need. We also wanted to call out here that there isn't a formal HEDIS screening measure in place for maternal depression. And when an informal study was done by Stigma Healthcare several years ago, the study found that 4% of OBGYNs were screening using what we call a validated screening tool or questionnaire during pregnancy, and 5% during the postpartum period. So again, no formal screening measure in place yet from a HEDIS perspective. We'll talk about that in just a moment. So we do recognize that the OBGYN should serve as home base, but there's also a belief that all providers, especially and including pediatricians who see mothers perhaps at their weakest once they have a baby in their office, and very frequently for well child visits, pediatricians and lactation consultants, given the real need and desire for women to breastfeed, and sort of the pressure, if you will, to breastfeed. Lactation consultants, we believe, play a critical role. There's really all providers, including doulas and midwives and primary care physicians, et cetera, that should be in a position to screen, and we call that no wrong door. So all providers should be screening, particularly when they detect that there could be a problem. So we also recognize, though, in order to help OBGYNs feel comfortable screening, that they need to have access to experts. So they're not trained in medical school around maternal mental health, or receive very little training, we know, which is one thing we're looking at fixing. But they want to still have access to experts, just like they do for other disorders or other medical conditions when they're treating their patients. And so we know that they need to have access to psychiatrists who have the additional training and expertise to treat women who are pregnant and in the postpartum period, especially when it comes to prescribing medications or understanding additional treatment options like ECT and TMS, things that OBGYNs just really shouldn't have to be in a position to sort of understand that advanced menu of treatment options. And again, if an OBGYN doesn't know what to do with the most difficult case, they're not likely to screen or diagnose any woman. So again, we know because there's an access to psychiatrists, or shortage of access to psychiatrists, and in particular reproductive psychiatrists, not an official term, but a term used in the field for those that have additional training and interest in maternal mental health and can keep up on the latest research, that we recognize there needs to be some type of psychiatric consult program in place. We also recognize one of the barriers for OBGYNs and even mothers themselves is that there is currently no credential that's issued or no testing that's done for these psychiatrists, like reproductive psychiatrists, or talk therapists like Dr. Hibbert, who have received additional training and have expertise to treat this population. And one of the recommendations from our movement is that a credential should be, a testing body should be created and credentials issued so that all of us can help identify those who are in a best position to treat these mothers. So we also believe that OBGYNs can't do this work alone, right? Even with all of those things in place, it's still a lot to ask. We've looked at, therefore, what are the other common denominators in a woman's life during this time in our current medical care system. And besides having OBGYNs, most having OBGYNs, 99% will deliver in hospitals, and most, of course, have insurance. And, of course, all of you offer your employees insurance, or you wouldn't likely be here today. So I wanted to start with, what can hospitals do? And these are some of the things that our cause believes. So we believe, because hospitals are in most communities, right, that they have ability to sort of scale and address that treatment shortage access in an interesting way. And so we're suggesting that hospitals be in a position to become experts themselves and have a trainer that can train staff, including obstetric providers, so OBGYNs in their community who deliver at the hospital, and also nurse midwives. We also believe that hospitals should be considering policies around protected sleep, knowing that sleep can be a trigger, lack of sleep can be a trigger for these disorders, and is critically important for mothers in the hospital setting as well. And also policies around non-traumatic birth. We also want to see hospitals implement supportive policies for neonatal intensive care unit families. Those that are in the NICU, we know, are at high risk for these disorders, as you can imagine. And we don't want to leave out and believe that hospitals can play a critical role in addressing birth loss like stillbirth, and even miscarriages when DNCs are conducted. We also know that hospitals are in a really great position to think about outpatient day treatment programs and inpatient treatment programs, and partnering with those programs that exist, which are few and far between. We can count them on our two hands now, those programs that exist throughout the United States. But to think about partnering with those that exist that are nearby, their service area, but also to develop those programs. And we here in Southern California and in other places have some new programs that are popping up and are starting to be developed, which is exciting news. Again, hospitals can play a critical role in providing critically needed outpatient day treatment programs and inpatient treatment programs. We also know that hospitals can educate women. They can do that in birth classes. They can also screen women for these disorders using one of those validated questionnaires, and do that in the NICU setting, right? When we know women are at high risk, they can do it at in an inpatient setting if a mother is pregnant, or even in the postpartum period, and of course an ER setting. We often will refer women to an ER if we feel like she's in danger or in danger of harming her child, and if the ER is not equipped to recognize these disorders, it can be disastrous as well. So what do we think insurers can do, the other common denominator? Well, to start with, and we want to hear your thoughts on this too, we really believe, and this is not unique to maternal mental health, but we really believe that insurers can start to rethink about how they deliver insurance and specialty care plans like behavioral health care plans. And we're suggesting that insurers take a look at dismantling the carve-out option. So as we know, of course, heart care for our heart, is not carved out. There is no Cigna Heart Care of California plan, for example, like there is a Cigna Behavioral Health Care plan. And we believe, of course, that the mind and the brain is just a critical organ as the heart. So what does that mean? It really means that mental health care should be reimbursed and addressed in medical policy, so insurance contracts with employers, and also through provider contracts, medical provider contracts, so that we really can leverage the integration movement that so many are trying to put forth in primary care settings, OBGYN settings, etc. We also think that insurers are in a really good position to develop case management programs, just like they have for other disease states like diabetes care, for example. And developing these case management programs can be critical for OBGYNs in particular. As all of you know, case management programs can help women find access to qualified treatment. They can also monitor whether she's receiving treatment and really can serve as a fantastic physician extender for OBGYNs. There's also an opportunity that until a HEDIS measure is developed to monitor how often OBGYNs are screening, that we can ask our insurance companies to voluntarily adopt a measure that was developed several years ago by ACOG, the National Committee for Quality Assurance, and the AMA, and it's a measure in the maternity care measure set. That information can be found on our website. You can see in that statement just below. The other two things that we wanted to touch on are you can ask your insurers to ensure that they have an adequate network of trained maternal mental health specialists and hospital-based treatment programs. That's hard to do, right, if they don't exist. But we do know that there are therapists, for example, who've been trained in maternal mental health that have a very difficult time getting into behavioral health networks, often because those behavioral health networks are just monitoring for the number of psychiatrists, for example, or the number of psychologists, for example, or licensed clinical social workers. So if there are already 10 in one zip code, they will decline approving a credentialing application for someone who's also, again, that psychologist, if there are already 10 psychologists. They're not always looking at specialty or subspecialty training, and we think you can ask providers or healthcare insurance companies and behavioral health care insurance companies to start looking at training specifically. And then finally, we know all of you are interested in value-based payment methods. And so think about encouraging your health insurers to continue to look at value-based payment methods and look at them relative to OBGYN care and maternal mental health. So now we're going to move into what exactly can employers do, and we've broken this down into three segments here. first, we want to suggest that there are some things that you can do when you think about your benefit offering. And the first is to simply ask your health insurers and their contracted hospitals. You can ask health insurers to do this for themselves and do it for their hospitals to address the recommendations you just heard about. You can also consider the cost of delivery as a potential cause of added stress. We know that there's great value in high deductible plans and helping patients choose the right plan based off of their expected healthcare needs. But we also know and hear often that high deductible plans can be a cause of distress when patients are already taking care of themselves and a newborn and dealing with all of the things that we've already heard about, that bills rolling in and not understanding these things and having to pay a lot out of pocket can be a source of stress. So it's something to think about. And then, of course, maternity and paternity leave and family leave. So there are some providers that we have heard that are actually prescribing to fathers when a mother is suffering to take family leave. And we know, of course, every state has different policies, but it is something that employers can think about specifically around paid family leave and also paid paternity and maternity leave. So what else? What about just general awareness and stigma? We heard Dr. Hibbert comment on this. So I know at some of the conferences that we spoke about earlier today, the Business Group on Health conferences, that there's a lot of talk about just the culture of understanding around mental health disorders, which we really want to lift up and encourage employers to think about. General training that can be offered to managers about mental health, and talking about mental health often in employee settings, posting brochures, just making it feel like the employer understands that these disorders are common, general anxiety or depression in its entire population, and then also acknowledging the nuances around postpartum and pregnancy-related disorders. And then I also am really excited to say that this month, May, is Maternal Mental Health Awareness Month. And so another simple thing you can do specific to this cause is do something like share an article on your intranet website about maternal mental health, and we will actually help you write something or actually give you some bullet points that you can use to write something yourself. So we're happy to help support you with that. And then there are also posters available. We'll talk about that free of charge. Post them up around the month of May or leave them in lactation rooms or in women's restrooms year-round. So in terms of workplace wellness policy, some things that came to our mind, and of course we're really interested in hearing from all of you as well, is what about helping to support moms, right? We know that those who are isolated, which we didn't touch on too much, but it really can be a risk factor, isolation, and that getting out of the house and connecting, or even connecting online, can really be protective in some ways, and of course even healing when we're talking about mild to moderate depression or anxiety. So think about pregnancy and postpartum mom connection groups. You can do that yourself if you're a large employer, or partner with a couple other employers on your street, on your block, to get moms together once a week or twice every other week for lunch when they're expecting around the same time. Lactation support, which we know many of you are already considering or offering now, space to pump for mothers who've returned to work. We also know that problems with breastfeeding can be a source of anxiety and even lead to deeper troubles when women aren't supported because of a lot of the pressure that they feel to give their babies the best, which is breast milk. So this is just a great point for you to think about diving deep into and how you can support these mothers. We also know that they want to talk to each other about breastfeeding and challenges, and are you having a hard time doing this, and what's worked for you, and that peer support can be really helpful. And then, of course, just general promotion of diet and exercise is protective and helpful in treating, again, a mild to moderate disorder. So think about how you do that for all of your employees, and of course don't exclude pregnant and postpartum women. So the next slide is, what can business groups on health do? And some of the recommendations that have come out of a white paper, we'll talk about that white paper in just a moment, that we wanted to share with all of you today are consider developing a working group within the business group on health to raise awareness and address maternal mental health disorders among your member employers. We've heard from at least one employer, and we think this is probably on the minds of quite a few of employers, that maternity care and behavioral health care are their two leading expenses, right? And so this is just a natural, a cause of natural interest, we believe, to many employers. Consider your role and ability to potentially collect information relative to cost for your employers. So what are the costs of untreated maternal depression or anxiety or the range of maternal mental health disorders, including the cost of extended disability leave, right, when a mother doesn't return to work when you expect her to, and also absenteeism. We even sometimes throw in presenteeism because we know, of course, that this can impact employees when they're not well, either suffering themselves from a mental health disorder or worried about their spouse or partner at home. We also think that business groups on health can play a critical role in promoting psychiatric access programs, so that provider to provider, telepsychiatry. There's some e-consult programs that are being tested, but that psychiatry access is critical for OBGYNs and other providers to really feel comfortable screening anyone and diagnosing anyone, again, for the need of support for dealing with those most difficult cases. And then finally, advocate for development and adoption of HEDIS measures. So we're going to close. We're just at 1 minute over here. There is my contact information. Actually, it looks like it has disappeared. There's Dr. Hibbert's contact information. I am going to tell you my contact information right now. It's Joy, J-O-Y, at 2020mom.org, so joy at 2020mom.org. And then also for those of you who are interested in pulling down the white paper, the report that was issued recently that includes those OBGYN and other healthcare provider minimum areas of knowledge and expertise. Those are documented in this report. There's also recommendations for all stakeholder groups. I've highlighted the ones that we thought were relevant to all of you today in today's presentation. But again, if you want to go deeper, feel free to pull down that report. Also on the 2020 Mom website, you'll see this information, free Maternal Mental Health 101 training. So we go into 2 hours of what we've hinted at earlier today. We go into that in a deeper way, and that's open to anyone. There's customizable materials where you can add your own logo to posters, for example. And then we have checklists for insurers and hospitals that you can use when you're shopping for insurance and thinking about your benefit coverage. And then finally, again, here's Dr. Hibbert's contact information. And we recognize that many of you may need to go, but I'm going to go ahead and open up the phone lines right now. And we would love to hear from all of you about questions, comments. What else do you think is needed? You're really the experts. You may have other great ideas that you want to share with all of us about things that you think can be done in wellness programs, etc. So I'm going to go ahead and unmute your phone lines now. All right, so if anyone does have a question, feel free to ask it now. Some of you are just getting unmuted. Any questions or comments that people want to share? All right, and it looks like I'm going to go ahead and mute all those lines. It sounds like some folks are on their cell phones, and that gives us some of that background noise. Well, so we did get one question that came in the chat box, so let me go ahead and bring that up. So if there was just one single thing that an employer could do to increase screening and or treatment of maternal mental health disorders, I really think that your leverage points are through your insurance carriers, and to have a candid conversation with your salespeople Get your medical directors involved at the health insurance carrier to say, this is an issue that's important to me. What are you doing about it? You already heard that kind of slew of ideas and things that we want to see all insurance companies start to do, but start a dialogue. Most insurers are not doing anything yet, and of course, as soon as they're educated about these disorders and the fact that you care about them, they will start to do something. So that's the single most important thing. Let me see, a couple more questions are coming in. For those who work in human resources departments, do we think it's permissible to have someone call in and check on a mom and see how they're doing? And do we know of any instances where other employers are doing that? Well, I think that's a really fabulous question, Jessica. What I would love to suggest that we do is, if anyone is interested in this, put it in the chat box or the question box and let us know. I think these are some of the things that we can address perhaps together in maybe a LinkedIn group, or even if we get ourselves on a small email chain to have these types of conversations. This again is Joy. I have not personally heard about employers doing that directly. I have heard about situations where nurse case managers, for example, at a health insurance company would make that outbound call, or even coaches, so not necessarily an RN, but others in that position would make a phone call. I think it'd be an interesting question to raise to your legal department, sort of about risk, and would that be sort of viewed as an uncomfortable form of intrusion or support? I think some women might have different ideas about that, but I think it's a really important question and conversation. The PowerPoint will be shared, so we'll make sure that we share the recording from today's session. And I have to admit that I hit record just a little bit late, so a portion of the recording today will be cut off, but it will be available. We'll also share the deck with all of you who registered. And then Linda asks, what about promoting freestanding midwife-led birth centers? And so, Linda, I think that's also a really interesting question, is do those women who deliver with midwives outside of a hospital setting, do they have lower rates of these disorders? And that might be what you're getting at. I don't think there's been studies on that specifically yet, and what where we've really focused is on where are the majority of women, so that we can kind of get the biggest bang for our buck. But I also think that that's a great question, Linda, and we do know that many women are interested in kind of alternative forms of medical care and birth delivery, right, and want to work with doulas and midwives. So I think you might be onto something, and perhaps if a woman feels more comfortable delivering in that setting, she does have less stress. So those questions I think are interesting to explore, and again, I'm not familiar with any research that's been done on that topic yet. So let me just leave you with one final thought again, and a question for all of you is, what do you think we should do next? Would any of you be interested in continuing to talk, at least online in an email exchange, or having each other's emails to bounce these types of questions off of, or even continuing conversation as needed in a LinkedIn group, for example? And perhaps some of you, and particularly the business groups on health, might have other ideas about things you want to do, and maybe even a business group on health would be interested in helping to engage folks in conversation in a LinkedIn group, and we're happy to kind of co-support that as well. So questions or thoughts on that, ideas? And let me just ask a simple question. Do you want more? Was this, I'm assuming, a little bit of a good introduction? Does anyone want more? What do you want to hear more about if you do want more? And use the question feature to give me that feedback. You don't have to ask a question, but can just give some feedback. All right, well, nothing coming back in on that yet, so we will go ahead and distribute the recording from today's session to all of you, including those who weren't able to join us live but registered. And you'll have access to my email through that email that goes out tomorrow. And feel free to keep the dialogue going with me. If you have any aha moments later tonight, or want to think about this with others on your team, let's keep the dialogue going if you have more questions and comments. one last point I do want to leave you all with, and I think the business groups on health have a particular, are in a particular good space to address this, is that we know a HEDIS measure will help drive change, right? Just as they have for other disorders and conditions. So once we measure something and those results are reported, people take interest, right? And insurers are in a better position to drive change. So again, Bryn, to answer your other question about what is one thing that we can do, I think employers ask your insurers what they're doing about maternal mental health. Business groups on health, we'd love to see you really push hard for a HEDIS measure. Well, with that, we'll go ahead and wrap up today's session. And I do see a few more comments now that you all are interested in continuing the conversation, and there's questions about protected sleep and non-traumatic birth policies and what those might look like. Great. So we'll go ahead and a LinkedIn group sounds great if someone has suggested. So we'll go ahead and think about ways, and I'd really like to hear from the business groups on health. I know, Deb, you're on, and Bryn, and I think Chris from Houston will be listening to the recording. We would love to hear from you in particular about how best we can connect everyone on these topics. If you'd like us to take a leadership role on doing some of that, or if there's something that you would like to do. We would really value your input and expertise and leadership as well. So great, we'll keep the conversation going and look for the recording and PowerPoint deck in an email tomorrow. Thanks, everybody.